Good morning. What day is it? It's Tuesday, right?
Tuesday, all day.
I swear, I feel like it's Friday. Okay, so we are here with my favorite person. This is Dr. Wiley. He is he's my personal functional medical doctor. And we're going to be talking all things HRT.
HRT.
And this
and
is
Cowboys.
And Cowboys. It's what day is it at the office
It's
today?
Redneck Day.
Redneck Day at the office. So he's come dressed. I love it. Put the hat back on. I love it. Okay.
Yeah. You got it, Missy.
So, Dr. Wiley, he is amazing. We've known each other for years and years and years, and he is so gracious to come onto my page and just share free information with you guys, because I know a lot of you guys are struggling with perimenopause and menopause, and one of the biggest questions I get asked all the time, I was actually just kind of prepping him, is about HRT. And because you guys, I'm on my own journey, I'm learning every time I do a live with him. I swear, I learn so much, and so I hope you guys will too. So let's start with, tell us about yourself.
Oh, well, I've been doing functional medicine for now almost 30 years. Functional medicine, if you're not aware, is just, I like treating people's whys, not just their causes, if you will. So rather than bandaging a symptom, we look for the reasons why people have what they show up in the office with and help them manage it or treat it themselves. And HRT is a big part of that.
Yeah, and we're just gonna dive. We're gonna dive into it because honestly, I think there's so many myths about it, I think. And so we're going to talk about that today. We're going to talk about why you need to be on it, or maybe you don't need to be on it. I don't know. We're going to learn. What is it? All the things. So let's start with a really common question, but also before we kind of dive in, if you guys have questions anytime during this live, I will be kind of trying to monitor that, and we can kind of jump into that. If it's not about HRT, we'll try to do it at the end and get into that, because I want to keep us focused. We have a hard time sometimes.
Oh yeah, there you go. That should be good.
Okay, so let's start with, what is HRT? What does it mean, and what is it?
So in most people's minds, when we say HRT, or hormone replacement therapy, we're discussing sex hormones. So testosterone in men, but there's a lot, DHEA, pregnenolone. In women, estrogen, progesterone, testosterone, and those others. That's what people think when we say HRT. When I think HRT, I'm thinking the 65 other hormones in your body as well that all change over time.
Yeah.
But classically, HRT is sex hormones, or you may see BHRT, which stands for bioidentical hormone replacement therapy. And what bioidentical means is just it's derived from either wild yam or soy, and the chemical structure, the organic structure of the hormone ringed molecule is identical to what you used to produce, versus something that is synthetic, or like Premarin. Premarin is a synthetic hormone. It is made from pregnant the urine of pregnant mares is what it is, hence the word.
Oh.
Premarin, pregnant mare.
Okay.
So that's artificial, because I think, and don't quote me on this, anywhere between 40 and 60% of that estrogen is equine estrogen. Now, I have a few patients that look like horses. No, I'm just kidding. But I have no horses for patients. I am not a veterinarian. But so I would much rather treat humans with bioidentical, or hormones that look like the ones God put in you.
Okay, I love that. So let's kind of break it down. And I might be asking some really elementary questions, because I'm learning, you guys, just with everything else. Okay, what are the different types of HRT? Is that a good place to start?
Sure.
Okay.
Yeah, if we're focusing on sex hormones, the primary hormones that are replaced are the estrogens, which there's 3, the progesterone, and testosterone. So to give you a little background on that, in a woman's cycle, when she starts her first cycle, we call that menarche, usually at age 13, 14, estrogen builds up the uterine lining. Roughly mid-cycle, you ovulate. If there's a sperm present and that egg gets implanted, it implants itself in the uterine lining that was built up by estrogen. If there's not an egg there, then estrogen starts to go down, progesterone comes up and sloughs off the lining. Mm-hmm. And in classic, even endocrinology, but definitely with our wonderful OB-GYN friends, progesterone is thought of as just that. It's a hormone of pregnancy, progestation, progesterone. Okay. But it does so much more than that. So a lot of the classic hormone replacement therapy, even using bioidentical hormones like an estradiol pill, they don't think you need progesterone if you don't have a uterus, and I would totally disagree with that. You need all the hormones for balance. Mm-hmm. So that's how a cycle goes. Testosterone is more steady state. Testosterone is released by the ovaries, it's released by the adrenal glands, and roughly 15% of it's converted in your skin. Oh. The importance of skin
Interesting,
health.
yeah.
Yes,
Yeah.
testosterone. So, and that peaks about mid-cycle, hopefully to get the libido up a little. If you're going to have babies, that's the time to do it, right? But it's more of a steady state release hormone. So hormone replacement therapy, using those, we replace those hormones. If I have a 45-year-old woman that's perimenopausal, I would try to bring her hormone levels back to where she was when she was about 30.
Okay.
Is how I picture that in my head.
Okay. So you're trying to even everything out.
Even everything out.
Okay. So who's a candidate for HRT? 2 questions. Who's a candidate for HRT? And is there an age limit of like, because I know perimenopause can happen, 35 usually, right?
Mm-hmm.
Unless you maybe had a hysterectomy or something that might
yeah.
change.
Any procedure on the uterus, including an ablation, hysterectomy and stuff, can actually change. It can throw you into early menopause.
Okay, so my 2-part question. Who's a candidate and what age do you kind of like start? And that's kind of a hard one probably.
Oh, not necessarily,
Okay.
because the candidate, if you're breathing, you're a candidate.
Okay.
There you go.
All right.
Number 2, it's very individual. I have women that have gone through early menopause in their 20s, and they're on full hormone
Wow.
replacement therapy. Yeah, there's a
Okay.
couple medical conditions that can do that.
Okay.
So anyone's a candidate for it,
Mm-hmm.
but we also have to realize that if you're not in the age group of perimenopausal, which by definition can start 15 years prior to true menopause, and in America that's age 51 on average,
Okay.
is when a woman stops menstruating, and the definition of menopause is no menstrual cycle for 12 months.
Okay.
So it's a clinical event. In the hormone world, we know that the hormones actually change up to 15 years prior. And so in my practice, if a woman's 35, I ask the perimenopausal questions
Yeah.
because it's starting to change. Then there's other medical factors. High insulin levels from being insulin resistant or overweight, high stress levels, cortisol levels, sympathetic tone, dysfunctional thyroid. All those things can cause a perimenopausal appearance.
Okay.
So you have to be aware of those and test those a lot of times to make sure you're not missing something. Because again, back to balance.
Yeah.
I can't just put you on a bunch of sex hormones, shake your hand and say, see you later.
See you later, right?
We got to look at all of it and then help you understand the lifestyle behind it too, which is how you eat, how you move, how you manage that stress, all those things. Relationships.
Which is why I love you as a functional medical doctor. This is what I keep saying. I get in my inbox all the time. It's like my soapbox because I only know so much, but this is what I do know, is that you are actually, from what I'm hearing, you're listening to people. You're listening to their symptoms. You're listening to what they're going through. You do all the tests. There's no normal range. It's based on that individual person. And there's so many women, like we've talked about before, that are just not being heard.
Yeah.
Or they're just getting birth control and sent out the office. And they're like, I still feel horrible.
Mm-hmm.
So what you're saying to me, I also really like, because at like 35, I think that my hormones are changing at 35, and a lot of us just at 35 are overwhelmed in life, maybe with young kids. You're not even aware of it.
Right.
And so like that 40, 41, 42, 43 is when I felt like I hit a wall, because all of a sudden I became aware of it, because symptoms got worsened, but maybe I'd had it for a while and just didn't know it, you know? So I love that. Okay.
Or you chalked it up to that stress, the
Yeah.
little kids and the travel.
No sleep, right?
Yes,
and all the
exactly.
things. And I think so many women are going through that, right? A lot of us have that high cortisol levels too, which also are huge.
Yes.
Another conversation.
Yeah, exactly.
Okay, so let's talk about, I've got my notes here. So let's talk about pros and cons, because on a really elementary level, right, a lot of people are like, breast cancer risk, I can't be on it. I have breast cancer in my family. Or I'm not a candidate because of A, B, and C. So what are the pros and cons of HRT?
Starting with the pros, I think that the benefits so far outweigh risk. It's not even funny. It's just, the analogy I like to use is when your car runs out of oil, do you replace it?
Right, yeah.
When you run out of hormones, you're running out of oil. I mean, hormone replacement therapy protects your brain, protects your heart, protects your skin, protects your bones, protects your mind, your emotions. It protects your sex life. I mean, all these things, the quality of life is so different without hormones, especially as we go through menopause or we go through changes or high stress events that whack all the hormones out. The pros are just so overwhelming, I can't even compare the two.
Right.
The cons, there's, and I could go way back, and I love medical history, so I could really bore your audience with the history of hormone replacement and women in particular, but needs to be, shortening it up, it's hormones in women have always been looked at as something to cover vasomotor symptoms. So hot flashes, night sweats, moods, maybe some docs, progressive docs would think sexual health. but it's really symptomatic treatment. It's not preventative like we view it.
Okay.
The side effects of a proper hormone replacement is it removes those vasomotor symptoms and improves sex life and all that kind of stuff. I use it to help a woman's quality of life.
Okay.
And when you help a woman's quality of life, you also extend their life.
Right. Because there's lots of research on that, right? Like being on HRT, you can be on it for your entire lifespan, right? Whereas before, I don't know, this is just elementary again. Don't know anything. I'm learning. It was for just a short amount of time, correct?
It still is. I see a lot of women from other practitioners that say, I'll give you hormone therapy, but you can only take it for 5 years.
Oh.
What happens then?
Yeah.
I hope they live longer than 5 years.
Yeah. So you don't need to wean off of it. You don't need to come off of it. You could actually be on it for your entire lifespan.
I have women in their late 80s still on it.
Really?
Oh, yeah.
And it just improves your quality of life.
It improves quality of life. And like I said, protects the bone, protects the heart, protects the brain.
Yeah. There's a lot of research, too, that I don't know. Once again, I've been reading, who knows, I probably did a Google search, let's be honest. But like cardiovascular health is huge with HRT, right? That can really help you like with heart attacks, strokes, things like that, too.
Yeah, why do women start having heart attacks and strokes in their 50s? Well, hormones are gone.
Interesting.
No correlation there.
That's so interesting. Huh. Okay, what about the breast cancer debacle that everyone talks about?
So where that comes from, and just to back up and give you a little more history, when Premarin was invented, which is an oral hormone replacement therapy, we didn't use a progestin or progesterone with it back. This is in the 50s. And we saw a lot of uterine cancer. Same reason I explained earlier, the cycle. The uterus lining is built up with estrogen. If progesterone's not there, slough it off, and it stays there. That can be a precancerous condition. So we saw uterine cancer in the 50s and 60s. When they decided to add a progesterone, which actually is a progestin, which means artificial. If I say progesterone, I'm talking bioidentical. If I say progestin, it's artificial.
Okay.
It's not what God made.
Okay.
They added a progestin called medroxyprogesterone acetate to Prem Pro, and then we stopped seeing uterine cancer, but now we started to see breast cancer. Okay. So I think it was 1996, a study called the Women's Health Initiative was started. And it had 3 arms, a nutritional arm, a hormone arm, and one other arm, I can't remember. But in 2002, they reported that estrogen caused breast cancer. Scared everyone to death. Everyone. Even to this day, people are like, I can't do it because of cancer.
Well, and even some doctors are saying.
Oh, totally.
So,
yeah, they really. But what you have to realize is hormones don't cause cancer. And I think the analogy of pouring gasoline on a fire is also incorrect. If you have breast cancer, you take estrogen, cause a fire, just like if a man has prostate cancer and you give him testosterone, it's gasoline on a fire. That's skewered thinking, because there are so many reasons for cancer. One, only 5% are related to your mom and history.
Oh,
so it's very small
genetics.
percentage that's actually genetically passed on.
Interesting.
It's lifestyle, exposure to toxins, stress levels, sympathetic tone, how much sleep you're getting, relationships. I mean, those are the things that cause cancer. If your body gets inhibited, if your immune system gets damaged enough or is suppressed enough with taking care of other things that it doesn't recognize cancer to get rid of it, that's a problem. And we call that senescence, is when the cells start misbehaving and the immune system can't take care of it because it might not even recognize it as bad. That's how cancer develops.
Interesting.
So when you have a woman with estrogen receptor positive cancer, progesterone receptor positive cancer and stuff, that's very personal. I have a number of women with histories that are on hormone replacement.
Really?
Because their quality of life is so much more important to them. And no recurrences, no issues or problem in my world, because we are so adamant about looking at all these other factors. Yeah. Right? Like using senolytics to wipe out those senescent cells, which are quercetin, the over-the-counter supplement. It's a senolytic. It gets rid of bad cells. Okay. So there's things we can do in the presence of breast cancer and still give women hormone replacement because of the quality of life is so important. Okay. So breast cancer, yes. I mean, again, if you're breathing, you're a candidate for hormones. If you're breathing, you're a candidate for cancer. It's just the way it is. So let's focus on all these factors that could be involved in both of those and help you figure out how to do it yourself.
I love that. Okay, let me see. I just want to quickly see if we have any questions kind of related.
I'll adjust my hat.
You adjust your hat. Okay, let's see. We missed a lot here, I think. Let's see. All right. Maybe we missed a lot. Okay. How can you... No, I don't... we'll get to that one later. It's not about HRT. Do you use a Dutch test to understand hormone levels, or how do you understand the current state?
Say that one more time, though.
Do you use a Dutch test to understand hormone levels, or how do you understand current state? I'm not sure. Do you understand that?
Yeah, I think I know what you mean. So levels can be quite misleading because normal values are this wide, right? And there's so many variables that have to be accounted for. The time of month in a woman's cycle. Have they exercised before the blood work? Were they eating before the blood work? I mean, there's a lot of variables that we have to look at. Different hormone replacement therapy, for example, if I have a woman on a topical cream, then the best way to check their levels is salivary testing because it's intracellular. Serum testing doesn't show it as well. The tests I use to confirm what I'm already thinking.
Okay.
In other words, like when we first met, if I may share,
Yeah, totally.
the
Please.
symptoms you told me, I said, okay, that's estrogen, that's progesterone, that one's testosterone, she needs DHEA. Because you told me. Did I have to check levels? No. Did I? Because you wanted to see them, and I like to say, yep, that's what I was thinking, and that's what we saw.
Right.
There was deficiencies in those, but we planned those tests according to those variables. We controlled those, and so in that case, and I hope I'm answering this question as they asked, yes, I use them, but I still want to hear it from you.
So you're listening to the symptoms first, and then the tests come second.
Right.
Which I feel like, from what I hear from a lot of women, is the tests come first, and the symptoms and what someone is saying kind of goes out the wayside with a lot of doctors that women are seeing. And that's, I think, the biggest frustration to women, right? Which is why we always say, go to a functional medical doctor. Find someone who will listen to you, because if your doctor is not listening to you, you're not at the right place.
Yeah.
Okay, someone did have a really interesting question, and I think I've stopped. Okay, I've been to 5 doctors, and no one has wanted to adjust my hormones. They say I don't need them. It goes back to the normal level range, right? Like we kind of talked in the last slide, but do you want to kind of address that? Because I know this is huge. Oh, my light just went out. Sorry, guys. Hopefully it's not too dark.
So yes, normal levels. Okay, first of all, there's a classic error in lab testing based on the scientific method that we use in research. And that is the rule number 1, and that is to remove the observer, right? So what we try to do in a research project is take away, if I'm doing a research project on testosterone in women, I have to remove my bias, because my bias will show up in the paper.
Right.
So remove the observer. But if you do that for labs, in other words, the example, you have a woman who had her labs done and then talked to the doctor, you have removed the observer. You're treating the labs, not the person.
Right.
So get the person's history, get the observer back into the equation, and then confirm it or deny it with your lab work. So, and again, back to the lab values being so broad and big, there a lot of lab values are going to what we call quintile distribution. So based on age and sex, we've narrowed those down. But there's literature out there that show these are optimal values. But once again, you weren't in those studies.
Right.
So what is Lauren's optimal value? When
It's
she
gonna be
tells me
different than
she
someone else.
feels good,
Yeah.
everything's working right, okay, we're at optimal values.
Which is why we meet a lot too.
Why we meet,
because
yeah.
we
And why we change over time.
Yeah.
Because right now your ovaries are still doing a little, but in 5 years they're gonna.
It's gonna be totally different.
And
Great.
so we
I
gotta
can't
do
wait.
brand new. We'll adjust the hormones accordingly.
Right, and that's one thing, and that's a good segue. So that's one thing too, is like I've heard from a lot of women that, you know, let's talk about me. I'm totally fine sharing my journey, just FYI, like, you know this, because this is what I've done. But like being on a compounded cream, we've changed it a lot, like a couple of times, because it's not that it just doesn't stop working, right? It's just that my levels have changed. Can you talk about that just a little bit? Because I think a lot of women are saying, like, I shared my HRT, what I'm using, things like that, and they're saying, you know, like, a lot of women are saying, well, that stopped working for me, so you should be on this instead. You want to do, like, estradiol is a big one too. I don't know if I'm making sense with this question, but do you want to take off on that?
To back up a little, there's 8 different delivery systems for female hormone replacement.
Okay.
You pick the delivery system based on the patient's needs and potential side effects. For example, if you had youngins at home, if you had little prepubescent children at home, I probably would not have given you a cream, because the chance of them getting into it is there, and they will go through puberty at age 6 if they get into it.
We talked about that, yes.
Yeah. So if you were a non-compliant person, I really like pellets. because...
Do you like pellets?
Uh-huh.
Tell us about that, because I have mixed feelings. Because for me, I tried it once, felt this amazing high, and then all of a sudden, nothing ever again.
Well, that's because it wasn't dosed up.
Okay.
A problem.
Okay.
It wasn't me. I did not see her for that one.
You didn't actually.
Yes, that's a classic issue with testosterone replacement when they do it unopposed, which means they don't do the other hormones with it.
Yeah.
Testosterone increases dopamine, your happy hormone.
Yeah.
So if your levels go to that of a man, you're going to feel amazing, but you will never get that back.
No, that's for
You never get that back.
Yeah.
It's Eric Clapton saw cocaine. Don't forget the fact you can't get it back.
Yeah.
And what he's talking about, doing lines of cocaine, you will never get as high as you would did the first time.
Which is the same thing. I felt like
With
a lot of women experience that.
Yeah.
Okay, I got you off topic.
You're
I'm
good.
sorry.
So the 8 different delivery systems, the topical creams are one that work very well. We do something called a bias, which is 2 estrogens. There's 3 estrogens, just to review. E1, which is estrone, E2, which is estradiol, and then E3 is estriol. So 1, 2, 3. Estradiol is the prominent female hormone, estrogen, in childbearing years. So a lot of people think, including practitioners, that's the one we need to replace. I use a lot of estriol, E3, and that's the estrogen of pregnancy because it doesn't cause breast or uterine proliferation, but it still manages vasomotor symptoms, protects the heart, protects the brain, protects the bone, but it doesn't cause the breast to proliferate or the uterus to.
What does that mean?
So estradiol,
For your dad.
we all know how when you're going through a menstrual cycle, breasts get tender.
Yeah.
Right? Or you're pregnant, breasts get tender. That's high levels of estrogen. It doesn't cause that proliferation in the breast. And the same with the uterus. Estradiol causes the uterine lining to build up and ready for an egg. Estriol does not.
Oh, okay.
So I use a lot of estriol in, especially women that have, let's say, had uterine cancer or had breast cancer. I'll use estriol because now I'm not worried about that hormone causing any issues, if that makes sense.
Yeah.
And it's still doing what I want it to. Okay. So the bias, there's different percentages. The most common one's called an 80-20 split. So 80% estriol, E3, 20% estradiol, E2.
Is that what I think that's
You're on a bias,
yeah.
80-20, yeah.
Okay.
And then we adjust that accordingly. As you get older, I may change it to a 90-10. I just had a woman yesterday, she's on a 50-50 split of the two in her bias. But then we can add testosterone to that, we add progesterone to it. I can add any hormone that can show up in a powder to a cream.
Really?
So I have some women that have their thyroid, their pregnenolone, their DHEA, estrogens, progesterone, testosterone, all in one cream.
That's amazing.
Yeah, that helps with compliance too.
That's amazing. So you don't have to be on like a patch, a pill. I mean, that's an option.
Those are options. Those are other delivery systems. Some people, and there's a small percentage of humans that do not absorb well through their skin.
Oh, okay.
And if every human out there, I'm convinced, absorbed everything through their skin, we would not be taking pills by mouth.
Yeah.
Because your liver gets it.
Right.
And it either beats the liver up or the liver beats it up.
Okay.
And it's called first pass elimination. When we put it on the skin, the liver doesn't get it as quick.
Okay.
And so, yes, there are pills, patches, troches, nasal sprays, intravaginal stuff. There's even suppositories.
Really?
Oh, yeah. Rectal suppositories for your hormone replacement.
Really?
No one's ever asked one for that one.
I don't want that one.
But it's there. It's there. And pellets and shots. There's a lot of ways to deliver it, but it really is up to the individual, their compliance, their risk factors, family around, like kids. They travel a lot. They may choose one route over the other. So, but the efficacy or how they work are very similar across the board.
Okay. So do you tend to do more compounded creams than you do anything else, or do you kind of do depending, like you said?
My practice is pretty even. I would say pellets, creams, shots, and oral are the top 4. And then I'll secondary classify women with vaginal symptoms, be it pain, be it with intercourse or anorgasmia and stuff. Then I'll use a lot of vaginal preparations.
Okay. That was good. That answered a lot of my questions there. Okay, let me see if there's anything else. Hold on. I just want to make sure that we're kind of answering questions as we go, if they relate. Someone said my OB-GYN said there was no way to monitor. I knew that wasn't true. That's not true.
Yeah, just ask the patient.
Yeah.
Go figure.
Oh, I have chronic joint pain, muscle pain, very dry skin, internal vibrations. My doctor only wants me on estrogen for 7 years.
Oh, well, that's not good. That's back to not treating the whole person there.
Yeah.
Testosterone's an incredible, you said joint pain, right?
Yeah.
Testosterone increases a cytokine called interleukin-10, which is one of the most powerful anti-inflammatory cytokines, or you can call them a hormone or chemical in your body. So I've had women with severe arthritis improve their RA, their rheumatoid arthritis symptoms improved by 50% when I started testosterone.
Wow, really?
Testosterone also increases sebaceous glands, so if she has dry skin, her skin will get better with that. Her joints will feel better, skin will get better. Testosterone tends to get all the credit and blame for everything sexual.
Yeah.
And it does so
that's
much
what you hear,
more.
but it
Yeah,
is
yeah,
for you.
yeah. And in women, a little bit, men more so, but really it does all these other things.
Yeah.
And if your husband pisses you off, I don't care how much testosterone you have in you, there ain't no libido.
That's right. That's right, men listening.
Yeah.
I don't have a lot of
Men,
men
I know,
followers.
yeah.
It's fine. They're not listening. Okay, so she probably needs to be looking at testosterone. Okay.
Oh, yeah, and just back to that balance.
All right, let's see. Anything else? I think what caused my Hashimoto's was estrogen dominant. Have any thoughts on that one? That's
probably,
kind of really...
Yeah, that's indirectly. Hashimoto's, just so people know, is an autoimmune thyroiditis. So the immune system, for some reason, took a look at her thyroid and said, that shouldn't be here, and it attacked it.
Okay.
And Hashimoto's is just one form of thyroiditis. There's a few. So I can say indirectly, without boring you with the pathways, that it was involved, but it wasn't directly the cause.
Okay. Okay. Someone wants to know what estradiol is. I know you explained it. Do you want to do it real elementary?
Sure. Yeah, estradiol, or E2, is the prominent estrogen in childbearing years. So from menarche, which is when a woman starts her period, until she goes through menopause, E2 is the primary estrogen. And so that's the one that I just touched on earlier. Providers and people think that's the one we need to replace because that's the one that's most active during our lifetime. But I think, again, it's back to the balance, and you can use the other estrogens. We don't use E1 anymore. When I was writing bioidentical creams in the 90s, we used to do something called a triest. Mm-hmm. And the triest was E1, E2, E3. Well, E1 we know through a pathway called 16-hydroxylated estrone and 4-hydroxylated estrone are inflammatory. So stuff like eating broccoli, using a supplement called DIM, changes that pathway to 2-hydroxylated estrone, which is the anti-inflammatory estrogen. So it's kind of was accepted. By early 2000s, we stopped adding estrone. Mm-hmm. But back then, when this was really kind of getting off the ground, was we tried to balance. Mm-hmm. So let's put all the estrogens in there. But now we really just focus on the two.
Okay. What is the hormone that causes weight gain?
All of them.
You looked at me like, that's a question.
That's a great thing.
I'm just reading.
This is very interesting. So progesterone, I will never start a woman who's cycling on an eating program after day 14 of her cycle, the last 2 weeks, her luteal phase, because progesterone makes you hungry.
Really?
And if I caloric deficit you in the last 2 weeks of your menstrual cycle, you're going to hate me. Oh. So always start a diet on day 1 of your menstrual cycle. There's less appetite. Okay. Just one example of many. Insulin causes weight gain if you're not. Insulin's your best friend or worst enemy. Builds your muscle or builds your belly. Cortisol does that too. And it's not necessarily scientific, it's more empirical, but I can look at a woman, if she was standing in front of me in a bathing suit, and say this is probably more insulin with that belly, and that butt's more cortisol and progesterone. And that
just by looking at the body and where they're gaining weight.
Mm-hmm. And if it's weight gain here, so really they have a lot of weight in their breasts and belly, that's estrogen dominance.
Okay.
So adding progesterone, testosterone, and balancing that out, they do real good with pregnenolone too. They'll start losing weight because that dominance is now balanced.
That's interesting because someone did ask that. They were gaining a lot of weight in their chest area. So, yep. Okay. All right. Let's see. Oh, how long does it take for hormone replacement therapy to start working?
Oh, that's a great question. So back to delivery system. On average, it's 14 to 21 days for steady state with a topical cream. So you got to do it for at least 3 weeks, in my opinion, before you can say anything about it. Oral is pretty quick, within a matter of a couple days. Injectable shots are also very quick. The troches, which are little things you dissolve under your tongue, the patches and stuff, those all work rather quickly. But again, it depends on where you are in your journey. If you're a 65-year-old that's never been on hormones, it's going to take a little longer to build those up, right? But if you're a 40-year-old who still has some hormones, we got to give it that time to do what it's supposed to do.
Yeah, I feel like it took about a month for me to feel like it was actually like something was kicking in.
Yep, exactly.
And even then, after a month, I think we actually adjusted again. And that's why I think it's so important that you have a doctor that's listening to your symptoms, because if you start this journey and they're not listening to you, you're never going to find the right balance, right?
Yeah, absolutely.
So,
that's so much more important, just to reemphasize again, than labs.
Yeah.
Talk, listen.
Yeah.
It'll make me cry. Sorry.
Aww.
So, sorry. I have a hormone problem. No, I'm just kidding. My preceptor, his name was Charles Basie. 50 years he was in practice. This is at the Mayo Clinic. My first day there, he sat me down and he said, Warren, if you listen, the patient will tell you the problem. Yeah. And then your job is to put a name on it. Mm-hmm. That was his first advice to me, and it's the best advice I've ever had.
You've never forgotten that.
Nope.
And it's so true. And I think that's why so many women are scared to come in to talk to a doctor. I know I was one of those, because I was like, if I'm totally authentically me and I'm explaining my symptoms, are they actually going to listen? Because no one has listened up to this point. And how many women feel that way, right? Yeah. I'm sure you see it all the time. And so the fact that that's how you run your practice, they all want to come to you. They're all asking where you're from. He's in Idaho, ladies. But yeah, I mean, I just think that's just the most important thing. Yeah, so many people don't listen.
Hands down. You will tell me what the matter is, what the problem is, what I need to do if I listen to you.
Yeah, I love
and
that.
Don't rely on the numbers. Don't treat numbers.
Don't treat numbers. Okay, I love that so much. All right, we're going to wrap up, I think, here in just a minute. I just want to make sure. Oh, DHEA. A lot of people are asking about DHEA. Is it good? Is it bad?
Oh, sure. So it's one of the adrenal hormones. Predominantly, it's also produced by the brain. It's one of the hormones we use in Alzheimer's disease, believe it or not. Dementia, we make sure pregnenolone and DHEA are adequate levels for brain health. But predominantly it's produced by the adrenal glands. It kind of is cortisol's antagonist. So if hand me that pin there.
Okay.
If this was, thank you, this just, visuals are always great. If this is cortisol and this is DHEA, and you come in here and your DHEA is like this, I know your cortisol's high.
Oh.
And vice versa.
Okay.
Right? So DHEA is an androgen, so it's in the pathway of testosterone. It's actually above testosterone. So it's involved in oil production in the skin, sexual health, hair health, brain health, like we talked about. Very important hormone. Very important. Again, balance, though, because too much DHEA in women will make them grouchy as heck.
So once again, listening to symptoms, listening to what they're actually going through, and then balancing that.
Yeah.
Okay.
And just to run down, it's over
Everyone's
the counter.
different.
So if you run down to the nutrition store and get DHEA and start pounding it, you might get a little grouchy.
Yeah, we don't want that.
Yeah.
I was already grouchy when I came to see you. Okay, these are some really good questions. Can you take HRT after 60, 65?
I have 80-plus-year-olds on it. Yes, it's again back to understanding the person, risks and benefits, evaluation, quality of life. We're all going to die. You might as well be dang awesome.
Feeling good, right?
Yeah, exactly.
I know, I agree. Okay, how safe is over-the-counter progesterone cream?
Great question.
Without testing or seeing a practitioner?
It's very safe because its dose is incredibly low. It too is derived from soy or wild yam. The dosings, though, are 1/100th of what I would prescribe.
Oh.
So they're just low dose, but they can be very beneficial for women if they just need that slight little balance. Women that really notice it well are the women with that estrogen dominance, so more weight in here, painful periods, excessive bleeding. On over-the-counter progesterone may do wonders for them.
That's what I was going to ask you. What are the symptoms for that? Okay, perfect. All right, a couple more questions, girls. I'm trying to get to everyone. Let's see. I know you said this before. What's the best place to find a functional medical practitioner?
Oh, A4M, so the American Academy of Anti-Aging and Regenerative Medicine, their website's called worldhealth.net. And then the Functional Medicine Institute, which, do you remember that website, Sarah? Sarah's behind the screen.
Yeah, she's taking notes, and we will have notes on all of this, you guys, just so you know, like last time.
Yeah, the Functional Medicine Institute's another awesome resource to find docs.
And you're writing that down, Sarah, right?
Yes.
Okay. We'll make sure that we have notes, and all of this will be linked, and just give me a minute after this, and I'll get it all done for you. Okay, let's see. Can your hormones change significantly from day to day? like high cortisol one day, low the next?
Absolutely. Oh yeah, remember the environment is still your biggest cue for hormonal response. And that's very important to understand and realize that you don't want to hang your hat because your symptoms changed overnight. Give yourself some time there. And again, back to all the different variables involved. The brain hormones in particular change like that. I mean, so yes, it can change day to day, but we try to look at what's the big picture here.
An environment can also cause something, right?
Yeah, environment.
Like
so
cortisol
toxins in the environment, stress, bad relationships are a huge issue that cause all hormones to go wacky.
Yeah.
All of them.
Well, you can see it affects your entire world, right?
Everything,
Yeah.
And the amount of, what you're eating, how much you're exercising, those are environmental factors that influence your hormones.
It's the Institute for Functional Medicine, right? The IFM.org. Yeah.
A lot of questions on DIM, because I've talked about that a lot. Mm-hmm. You have me taking it. Is it okay? Hold on, I gotta find that question. Is it okay? Where'd it go? Is it safe to take DIM without seeing a doctor? People are really worried about DIM. I don't know why.
So DIM is diindolyl methanate. It's also called I3C, indole 3-carbonate. There, sorry, I couldn't think of the name. Those are chemicals produced by broccoli, cauliflower, collard greens. That brand of vegetables make DIM, and that's why broccoli is directly related to lower breast cancer risks and lower prostate risk in men, because that DIM changes that estrogen conversion I mentioned earlier. If your body's left to its own self, it takes estrogen and puts it down what we call 16-hydroxylated and 4-hydroxylated estrone pathways. Those are inflammatory. Okay. You could call them pro-cancers. But the DIM forces it down the 2-hydroxylated estrone, which is anti-inflammatory. So you can't go wrong with DIM.
Okay, that was
Eating
like
broccoli is your best bet, but to get the amount of DIM that I prescribe, it's like 5 pounds of broccoli a day. You wouldn't have a friend.
No, you'd be stinky.
Yep.
Okay, one more question. This one I thought was interesting because I don't know anything about this, so I thought maybe you can enlighten us on this one. Now I lost it. What does your lovely doc think of Vagifem for painful sex during... painful sex being my only symptom? Vagifem, is that right? Is that how you say it?
Vagifem, yeah, I think you're missing something there too. That's just estrogen. DHEA for dyspareunia, that's the medical term for painful sex, is a godsend.
DHEA.
Local DHEA cream that we have compounded. And my combo for that, if someone came in with that, we would try very low, so 0.01 of E2. I would do probably 1 to 2 milligrams of DHEA. I would do 1 to 2 milligrams of testosterone, and I would put some Viagra in there, sildenafil.
Interesting. Okay.
That's my cream for dyspareunia. Put that around the vaginal intrus, around the clitoris and stuff, every night before bed for a week, and then use it 2 or 3 times a week following.
Mm-hmm. There you go.
Good stuff. So yeah, Vagifem works. It's just not complete.
Okay, and they can just talk to their doctor about that. Okay.
That has to be made. That's a compounded combo.
Can anybody get a compounded cream? I get that question a lot.
They have to go to a doctor to get a prescription, and then if there's a compounded pharmacy in their place,
they have to have a compounded pharmacy.
Yeah.
That's
the case.
Okay.
Walgreens does not have one. Neither does Walmart.
Okay. Yeah, that's why I get that question a lot. I'm like, I don't know. Okay. Thank you.
Yeah,
You're amazing. I hope this was helpful for you guys. Like I said, if Dr. Willie will do this every month with me, we'll just keep providing so much information because he is like a wealth of knowledge. He also has some books that I'm going to be listing. So if you want to at the end of this live, not yet, I have to post it, but comment notes and I will send you all this information, his books including, information on him. You're not super active on Instagram, so if you DM him, you might not hear back. You might, I don't know. Are they gonna hear back if they... No,
only if I respond, and I won't.
Okay, so no, don't DM him on Instagram. But a lot of times, if you ask me a question, I text him. He gets right back to me. So thank you guys seriously for hanging out with us. Thank you. You're amazing. I always have so much fun, and we'll see you.
Find out what hat I should wear next time.
I know what hat. Yeah, should he wear a hat next time, ladies? What should we do?
Shine ahead.
All right, we'll see you guys next month, and we'll have a whole nother topic. So
thank you.
All right, bye guys.